Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, UTSU's Bill Gatton College of Pharmacy. It is January 29th, 2026. What a great day. Today we're going to talk about the Patina trial, which was just published in today or yesterday's, this week's issue of the New England Journal of Medicine. And this is palbociclib, brand name Ibrance, for hormone receptor positive, HER2 positive advanced breast cancer. You know that cyclin-dependent kinase inhibitors for going back probably a decade have been, really a mainstay of treating hormone positive, HER2 negative metastatic breast cancer. And this is, an entry of this drug, we'll see, into the HER2 positive space. And again, this is the Patina study. Just as a backdrop, the current way, historically, we've treated HER2 amplified breast cancer would have been taxane-based chemotherapy with trastuzumab, taxane with trastuzumab instead of an anthracycline because of the anthracyclines having cardiotoxicity along with trastuzumab as a toxicity risk. Historically, going back before the Herceptin or trastuzumab era, anthracyclines had really great activity in HER2 amplified disease, which is at about 20% of breast cancers. So today, kind of the preferred regimen, if you look on the guidelines, would be docetaxel for at least 6 cycles, or as long as the patient could tolerate, plus trastuzumab and pertuzumab. That's 1A. 1B would be paclitaxel in place of docetaxel. And then another kind of, if you think of this as a horse race, coming up the rear, coming from behind, and maybe perhaps likely to catch the THP, where T is taxotere, H is Herceptin, and P is Perjeta. That docetaxel, trastuzumab, pertuzumab regimen is going to be FAM, trastuzumab deruxtecan with pertuzumab based on the Destiny Breast 09 study, which showed a very large progression-free survival benefit. But the OS data are immature. Once those become mature, it'll be interesting to see if that becomes, the 1A replacing the chemotherapy-based backbone, which I think is, I don't know, I'm not going to say it's likely, but certainly it's possible. So getting into this study, the Patina study, as we look through, the background here, this was a question that came up, a long time ago, because you'll have these patients in clinic who are, they're hormone receptor positive, either ER or PR positive, and HER2 negative, and then they have a site of metastatic disease, you biopsy, boom, suddenly out of nowhere, we have a lesion that's HER2 amplified, and before they weren't. And you see this discordance sometimes, and the question would come up, can we use, we know that they have estrogen receptor positive disease, we know the CDK4/6 inhibitor can work, could you use that in somebody that is HER2 amplified? Is there any biological reason you couldn't? And based on, cyclin-dependent kinase's role in the cell cycle, between the G1 and the S phase, doesn't make any sense why it would not work. But it hasn't been used there, and perhaps it wasn't really studied there, because if you're going to make a drug and you're going to sell it for money, you start with the 80% block of a patient population, those who are not HER2 amplified. And then the HER2 amplified space has really great targeted drugs already, starting with trastuzumab. There's a reason we call it the trastuzumab or Herceptin era as such a good drug. But some of the preclinical studies have showed that there's some crosstalk between HER2 and the estrogen receptor signaling pathways, and blocking one, the other pathway could be used as a way to basically a mechanism of resistance. And so that's kind of where this idea came from. These were, first-line treatment in the metastatic setting. They could have had prior treatment in the past, and they had to get at least 4 cycles, no more than 8 cycles of chemotherapy. And the median number they received was 6, which is what you would plan at least to get with docetaxel. Beyond 6, you're probably getting a little bit of benefit, but really it's probably tough for folks to tolerate. One thing that is notable here is they actually had planned to allow up to 20% of people in the study to only get trastuzumab and chemo, not pertuzumab, which would not be the standard of care. This is a little bit of a carve-out because this is going to be an international study, and there are some areas of the world where they may not use pertuzumab. In this case, actually about 95% of folks were getting pertuzumab and the trastuzumab as well. And then, so they got the chemo, what we're calling induction in this study. So induction, taxane, and trastuzumab and pertuzumab. And then, once you get 4 to 8 cycles, most of them got 6. All right, so you get 6 cycles of chemo and your dual HER2 blockade. If you have not had disease progression, So you have complete response, partial response, stable disease. Then and only then were you randomized to maintenance therapy with dual HER2 blockade plus or minus palbociclib. And they're stratified, these patients, when they're randomized by, did they have a response or stable disease? Did they get dual HER2 blockade, which they all did for the most part? And then were they getting AI or fulvestrant? And almost all of them were getting an aromatase inhibitor. One notable thing, so the primary endpoint here is investigator-free survival. Investigator progression-free survival. Not surprising, but a little bit disappointing here for a metastatic disease. I'll point out one thing that's a little odd here in the methods. The palbociclib, the dosing is the standard dosing, and they're doing a CBC at baseline, day 22 of cycle 1, and then on day 1 of every cycle through 4. And then after 4 cycles, they go to every 3 months. And certainly if you've worked with a lot of patients taking palbociclib, ribociclib, and even abemaciclib, which causes less neutropenia, you'll see folks that have been on these drugs for years suddenly needing dose reduction. So to just go 3 months without checking a CBC on a drug where the most common side effect is neutropenia seems a little, well, I'm not going to do it. Anyway, we'll skip the stats here. The interesting thing about the statistics, which we don't really get to talk about, is that they do have a one-sided alpha of 0.0002 that they're going to use on overall survival for hypothesis testing. Since the PFS, spoiler, is statistically significant, those results are immature. They don't even give raw data here or in the supplement about what the OS is looking like that I could see. So we'll have to wait to see that. As I alluded to earlier, the trastuzumab deruxtecan plus pertuzumab has PFS benefit, hasn't quite made it up to the category 1 level recommendation because we're waiting on that OS maturity to see if it actually does improve overall survival in the first-line setting. So we're going to wait for that for this study as well, of course. These patients were enrolled from June 2017 to July 2021, so catching the beginning of the COVID era. Median duration of follow-up was 53 months. And we see, a statistically significant improvement in progression-free survival. Oh, before I do results, let's talk about these patients. They're about 250 in each arm, so 500 people, reasonable size study. Median age is 53, so kind of on the younger side for an advanced breast cancer population. If you think of all breast cancer, not just HER2 amplified, 80%, roughly 75 to 80% white. Less than a third were in North America. 40% ECOG 1, the rest ECOG 0, and kind of maybe reflecting a younger patient demographic. 37% were premenopausal. They're all hormone positive. 75%, 77% roughly are HER2 3+. Now the other 2+ with ISH amplified. So this is not HER2 low. These are all HER2 amplified, tried and true HER2 amplified. And unlike in hormone-positive HER2-negative breast cancer, where a lot of times the site of metastasis and bone here, 3/4 of these patients have visceral metastases, so lung, liver. And as I said, they got a median 6 cycles of induction chemo. Half these were de novo metastatic disease, and there were some that had, maybe a third who had prior HER2-directed therapy in an adjuvant or neoadjuvant setting, but it did have to be, 12 months before. They had to complete that before they could be enrolled in this. So when you look at our progression-free survival here, if you look at the top-line result, median PFS, 44.3 months with the palbociclib group versus 29.1, seems like a huge improvement in progression-free survival. If you look at the curves, though, these curves are very, very, very parallel. And so we really are skimming the mean here because, the difference, the median or the magnitude of improvement in progression-free survival at 12 months is about 12%. At 24 months, it's about 10%. At 48 months, it's about 8%. So those are, the benefit is hanging there throughout the whole time. It's a little bit different in the PFS curve we see in the DESTINY-Breast09, where there's a larger separation between trastuzumab deruxtecan and pertuzumab compared to just trastuzumab and pertuzumab maintenance. They're a little bit different because DESTINY-Breast09, they're counting from randomization, starts from when you first start treatment for advanced disease. Here, we're starting our randomization after they've completed, in most cases, 6 cycles of chemo already. So it's a little bit different. Similar, I guess, just eyeball to eyeball median PFS you're seeing in the folks who aren't getting in both control arms in these studies. So, we're seeing some modest improvement in PFS I guess I would not say that we should focus on the median PFS, but the hazard ratio here of 0.75, that 95% CI is 0.59 to 0.96, which is relatively wide for a study with 500 people. Again, you're seeing modest benefit here in the palbociclib arm, in my opinion, even though you have what looks like a huge magnitude of benefit with the median PFS. If you look at the PFS curves, you very clearly can fit a laser pointer between these curves. You probably can't fit 2 laser pointers between these curves, though. All right. So this is, reasonable magnitude of benefit for progression-free survival. We don't know about overall survival yet. We'll have to wait on that. The other thing that I think is really important to pick out of this study, of course, there's a whole lot more neutropenia in the palbociclib arm than in the HER2 arm that's getting the AI as well, or fulvestrant. What is really notable to me, and honestly, I'm gonna stick a feather in my cap here, because the first thing when I saw this, last night I get the email, this week's New England Journal of Medicine, boom, I look at it on my phone, while I'm making dinner, and I'm just looking to see, is there an oncology study, and I see there's a palbociclib and HER2 amplified. He's like, okay, interesting. I can't wait to read this. And I bet they'll never try this with abemaciclib. There'll be too much diarrhea if you added abemaciclib to HER2-directed therapy. We know HER2-directed therapy causes diarrhea. HER2 is an epidermal growth factor receptor family transmembrane receptor, so we know that diarrhea is really an on-target side effect of HER2 blockade. Even with trastuzumab and pertuzumab, let alone your oral TKIs like lapatinib that target HER2. Well, 70% of patients in the palbociclib arm had diarrhea, and 10% had grade 3 diarrhea. That's so much, diarrhea that you're probably getting into the hospital for dehydration. That is not insignificant, and it's really going to be curious to see what our patient-reported outcomes look like for patients. Is this diarrhea something that is manageable? Is it a chronic side effect? A decent number of patients in the study had to have dose reduction. Most of the time that was probably for neutropenia, because 60% had grade 3 neutropenia. But that's surprising. 14% had hypokalemia, probably as a consequence of the diarrhea that you see here. But the diarrhea you see in the registry studies for palbociclib are 25%. Okay, so palbociclib plus trastuzumab and is getting you, and pertuzumab is getting you up to like 3 times as much diarrhea, and that's going to be really impactful in a deleterious way on quality of life. So where does this leave us? I don't think anyone's going to be adopting this right now, but it is something to watch. You might have this scenario come up in practice where patients, they do their chemo. Maybe they've had taxane in the past. They had, say, AC followed by T, THP in the curative setting, and they recur some months later. It may not make sense to go back to a taxane-based regimen. And maybe those folks would do a trastuzumab deruxtecan up front. That might make some sense. It can be a tough one to follow. Now, then some folks will say, well, now we have data about doing palbociclib with endocrine therapy in HER2-amplified disease. Let's put people on this after they've had trastuzumab deruxtecan. And, we don't have, there may be some smaller data there that I don't know about, but we've already seen using palbociclib plus trastuzumab and pertuzumab, we're seeing, a lot of diarrhea. That is probably more than was expected in the study. They even comment on it in the discussion. They say grade 2 or 3 diarrhea in the palbociclib group, particularly early on, and among patients who had diarrhea at baseline, may reflect residual toxic effects from chemo or overlapping effects from pertuzumab and palbociclib. That could be, or it could be together, this crosstalk between the hormone pathway or the CDK4/6 and HER2 really is going to cause a lot more diarrhea. And so if you do a drug like palbociclib, which does have a risk of interstitial lung disease, and people have already had trastuzumab deruxtecan, which has a fairly high risk of interstitial lung disease, do you get an unsatisfactory high number of risk of interstitial lung disease? We don't know. Something that would have to be watched. But I could see folks even trying to do induction with trastuzumab deruxtecan and then maintenance with palbociclib and endocrine therapy and HER2 treatment afterwards. So that would be worth maybe studying, but off-label would give me some pause if somebody tried to take part of this study and combine it with part of that study, which is not which is not a foreign practice in oncology, but something that should certainly give us pause. Well, that is what I have this week. More snow coming our way, and because of that snow, I'm going to curl up with a nice. Usually, I used to drink, on the weekend to relax. Maybe have a bourbon on the rocks. Going forward, bourbon, no ice for me. So thank you so much for listening, and until I talk to you again, remember, doses matter.